let's go through the presentation and see how we can get the quality improved with regard to prevention. Because with a lot of difficulties, we are getting the dates for a CT scan or an MRI. If patient misses that, then it is going to be postponed. So I'm thinking when I'm taking decisions related to contrast-induced nephropathy, I have to think that part as well, not only the kidneys. So we have to strike a balance. So we'll see. So first, moving on to the terminology. So now there are two entities. This is contrast-induced AKI or contrast-induced nephropathy is what we say as, now patient has received a dose of contrast and next day patient develops an AKI. So whether this is really due to the contrast or whether this AKI has developed in the background of a contrast study where other factors are also playing in. For example, now a patient who is in a critical state, say a patient is having a myocardial infarction, and now we are awaiting a coronary angiogram. And when we give contrast study, next day patient creatinine rises. So whether this is really due to the contrast, or could this be due to the myocardial infarction itself? And patient might have received certain drugs, and whether it is due to that. So there are a lot of factors playing around when it comes to an acute kidney injury. So sometimes it's hard to tell this AKI whether it is due to contrast or whether it is due to something else. So that's why we introduce these two terms, contrast-associated AKI as well as contrast-induced AKI. So contrast-associated AKI is to give contrast, and then there is an acute kidney injury. We really don't know the reason, but it could be due to contrast. And the next term is the contrast-induced AKI. So by exclusion of the other causes, so we think what could be the reason for this AKI, whether it is MI or there is an infection. So we try to do certain investigations and exclude the other causes. And then we know that this acute kidney injury is most likely due to the contrast. So then that's where we can label this as contrast-induced AKI. So moving forward, so to you to say contrast-induced AKI or contrast-induced nephropathy, there should be a causal link between the contrast exposure and the onset of the acute kidney injury. And in other words, we need to exclude the other causes. So moving on to the definition of contrast-induced AKI, it's basically impairment of the renal function. We give a number like 25% increase of serum creatinine, or if we give it in the hard numbers, it is 0.5 milligram per deciliter creatinine wise. If your creatinine is 1 and if it is 2 next day, so then it could be acute kidney injury due to contrast. So that's the definition. And look at this definition. The most important thing is it's within 48 to 72 hours. So that's the critical part of this definition. And the most important thing to differentiate it between other AKIs in the same background. Because typically, the contrast-induced nephropathy, the onset, if at all, majority of the people who are getting contrast-induced nephropathy, the onset is within first 24 hours. That's important. And it can onset a little bit later, maybe up to 72 hours, but very unlikely to get onset after that. So if there is an acute kidney injury or the creatinine rise happening, say after 3-4 days, so it's a little bit unlikely that this is contrast-induced. It could be something else. And the numbers wise, 80% of the time, the onset is within first 24 hours. So that's why we sometimes ask to do the creatinine the next day. And sometimes I ask to repeat the creatinine in like 72 hours time. So if the creatinine is normal in 72 hours time, that means it's unlikely that there is a contrast-induced. Okay. And also it mentioned that in the absence of other identifiable causes. So it's a diagnosis of exclusion. So why we talk about contrast-induced nephropathy? So now you can see it's the third most common of acute kidney injury in the hospital setting. It's just as acquired renal dysfunction, only being third place, going to third place after surgery and the hypotension. Hypotension is either septic shock or cardiogenic shock or a drug-induced shock. So that's the commonest cause of acute kidney injury in hospital setup, hypotension and the surgery. And this is the third cause. So that is quite important. And as we all know, the availability of contrast studies, it's right there. It's available, and we tend to use it quite frequently because they are so helpful in making diagnosis. So because of the availability, the usage is going up, and so as the incidence of CIN is going up. So the important thing is the contrast-induced nephropathy. We will go into the pathology. The important thing is once you get the contrast-induced nephropathy, there is hardly much as to do. You know, there is no cure, there is no treatment for contrast-induced nephropathy. So the important aspect is the prevention. So identifying people who are more prone to get contrast-induced nephropathy and identifying factors which we can change, that is going to change the cause of the contrast-induced nephropathy, but not after the onset. So identifying preventable and modifiable risk factors is the foremost important thing. And so the other important thing which a lot of people forget, the acute kidney injury, irrespective of the cause, it does not remain in the kidney. It's a systemic disease. Acute kidney injury is not only affecting the kidney, it's affecting the whole system. So if you get an acute kidney injury, your creatinine, say you get a contrast-induced nephropathy and you manage to give fluids, and the creatinine will improve in a few days' time. Okay, see, there's nothing much there. Okay, creatinine improve. Well, there is an inflammatory cascade getting activated with the acute kidney injury, and the effects sometimes can last up to years. And this is acute kidney injury is associated with increased mortality in the short term as well as in the long term. So that's the importance of identifying the modifiable risk factors and prevent getting acute kidney injury, prevent getting CIN. That is going to reduce the mortality, and that is going to increase the lifespan of the patient. So going into a little bit of history. Now, the first evidence came about acute kidney injury associated with contrast are coming from 5th decade, it's 1950s. Where people saw people with myeloma, they were undergoing certain contrast studies, for example, intravenous pyelography, and there's the rate of acute kidney injury at that time is 70 to 80%, so which is massive. And so that is the first sign that people started to talk about contrast-induced nephropathy. Okay, so this is likely due to contrast, and in fact, it is due to contrast. You know, myeloma can also cause acute kidney injury. But there are a lot of evidences that this is due to contrast, right? And so these historical figures, these numbers I took from a paper published in 1977, where the contrast-induced nephropathy rates were among like up to 40% in non-diabetic patients, and people with severe chronic kidney disease, the rates were up to 50 to 90%. You can imagine the number, which is it's quite severe and quite common at that time. But is it as common as that in the current era? The answer is no. The reason is the types of contrast media we used in those days are quite different to what we are using currently. So there are two factors associated with regard to the contrast. That is the osmolality of the contrast, that is, how concentrated it is, and also whether they are ionic, whether they have a charge of that contrast media. So a contrast medium with a charge and also contrast medium which is very concentrated can exert more nephrotoxic effects compared to something which has a lesser osmolality. So what we are using these days is less concentrated contrast media. We'll go into detail later on. So which are associated, the number is not as severe as in the good old days. So the numbers in 21st century, the people who don't have chronic kidney disease, the chances of getting a contrast-induced nephropathy is kind of negligible. It's less than 1%, right? So, so if the creatinine is normal, your worries are less. But at-risk patients, especially people with diabetes, and mind you, in diabetics, even if their creatinine is normal, you know that they can have chronic kidney disease because of ongoing proteinuria. So they are more prone to get acute kidney injury due to contrast. even if their creatinine is normal, if they are proteinuric. But if your creatinine is high, of course, you are at risk, depending on the EGFR. We'll discuss it later. But when it comes to the numbers, the coronary angiography is the kind of investigation or the procedure which is associated with highest numbers of chronic the contrast-induced nephropathy. It can go up to 30%, which is very significant, right? 1 in 3 of person who is undergoing coronary angiogram with chronic kidney disease, they can get contrast-induced nephropathy. So, what's the pathophysiology, and how do we know what is happening in the kidney? So a lot of data are coming from mostly the animal studies, as you know, because there are histological changes undergoing in the kidney when kidney is getting exposed to the contrast. So we routinely don't do kidney biopsies in human to diagnose contrast-induced nephropathy, because obviously the cause it's apparent. You give contrast, you get an AKI, so most likely it's contrast. So we don't do kidney biopsies, but there are a lot of animal studies being done, which is shown clearly that contrast is associated with kidney injury. And you know, in the kidney, you have the cortex, which is mostly containing glomeruli, and you have the medulla containing tubule. So it's basically tubular necrosis you are getting as the pathology in contrast-induced nephropathy. So this is like a rough sketch to describe what's happening when you receive a dose of contrast. So contrast molecules, they go into the blood, and then ultimately it will be excreted through the kidney. So it gets concentrated in the kidney. And there are two effects happening in the kidney. One thing is, due to the contrast, you get direct cellular toxicity in the kidney. So it can affect the vascular endothelium, the glomeruli, and also it can affect tubular epithelium. It can cause cell death. And that is one way you get tubular necrosis. And when it affects the vascular endothelium, it can cause renal vasoconstriction, the glomerular vasoconstriction. So what happens is, there is no direct renal damage, but blood supply coming to the kidneys, suppressed because of the vasoconstriction. So that is one of the most important mechanisms. So because of lack of blood supply, so kidney gets ischemic and get necrosis. And on the other hand, the contrast, sometimes it gets concentrated and it increases the viscosity of the urine inside the tubules. And because of the viscosity, you can get kind of a tubular congestion. Tubular congestion also can cause cell death. And, ultimately you are coming, either it is reduce renal perfusion or increase renal congestion. Ultimately, you will get tubular injury and manifestations of acute kidney injury. So what are the clinical features of CIN? As you all know, it's a creatinine rise, right? So that's the most common thing. So the rise of serum creatinine. And the important observation is they hardly get oliguria, right? Even though they get acute kidney injury, their urine output is mostly preserved. They can get oliguria in severe cases, but most of the time it's normal urine output, acute kidney injury. So rather normal uric acute kidney injury. So serum creatinine rise, we discussed, it happens in first 24 hours, 80% of the cases. And serum creatinine typically peaks in 3 to 5 days time. So that's where you peak it, and it starts settling quite quickly, right? So usually within a week's time, most of the time it settles. And sometimes it can take up to 3 weeks, but less commonly. And if somebody gets oliguria, it develops within first 24 hours. That is also very a good observation because it's so acute, and the changes happening in the kidney are so acute. So that's the reason, right? So that is also important when we are thinking how to prevent contrast-induced nephropathy and how to treat. So as I said, the observation is there's a relatively rapid recovery of renal function, and whether you are having CKD or whether you are not having CKD, and most of the time, the devil is not as ugly as we think. If creatinine improves very rapidly, and you are really creatinine is improving. But as I said, the aftermath is quite long-standing. So moving on to this topic a bit. Now, I told earlier, one of the commonest causes of acute kidney injury associated with contrast nephropathy is with angiograms, right, rather than contrast CTs. So there's a reason for that. So we'll discuss. So when we give contrast, which is getting concentrated mainly in the venous compartment, like when we do in contrast CTs, the chances of getting acute kidney injury is less. But if you do an angiogram, we want that contrast to get concentrated in the arterial compartment, right? It's more kind of intra-arterial contrast. Either it is coronary angiogram, or either it is lower limb angiogram in peripheral vascular disease, or either it is cerebral angiogram when you do to diagnose arteriovenous malformation or aneurysm. So it is, when it is concentrating in the arterial compartment, the chances of getting acute kidney injury is pretty high compared to contrast in the venous compartment. So now, people who are subjecting to angiograms, there is another mechanism they can get acute kidney injury, right? So when we are putting a contrast, when we are putting an instrument, catheter into the arteries, we are passing a lot of atheromas, right? So in the artery, there are a lot of atheromas. So when we are sending this contrast, so it can cause cholesterol embolizations, right? So it is very common that after coronary angiogram or a lower limb angiogram, you get cholesterol embolism. So that can cause acute kidney injury independently. These cholesterol emboli can go and deposit in the kidney, and that can cause. So this is not CIN. So that is atherembolic AKI. So sometimes now, for example, few years back, people were arguing whether there is actual acute kidney injuries happening with contrast, or whether this is just due to this atheremboli, or whether it is due to some other factors. So, and people are trying to compare the clinical manifestations of atherembolic AKI versus contrast AKI, and whether to say that whether a real CIN is existent. But the thing is, atherembolic AKI, the onset is slow. So as I said, contrast-induced nephropathy onset is very quick within first 24 hours, but atherembolic AKI, the onset is very late, and mostly it is after 72 hours. So now, with the studies, people understood that these are two different entities, and there is actual CIN existent, and we need to differentiate between two. So there are a few factors I have mentioned to differentiate between atherembolic, but the most important thing is onset is very late, and usually atherembolic AKI is very, very difficult to manage. They don't improve easily, and it will have a protracted course compared to CIN, where the improvement is very brisk. Right. So why there is rapid recovery in CIN? It's still in the investigative phase, but what we have understood so far is the tubular necrosis you are getting with contrast-induced nephropathy is less. The degree of contrast tubular necrosis is less compared to other causes like sepsis AKI or hypovolemic AKI or drug-induced AKI. They get severe CIN, severe tubular necrosis, so the recovery is late. And also, there are some evidence to say that in certain people, they only get vasoconstriction of the renal vessels, and they don't get real tubular necrosis. So with the vasoconstriction, you will get a creatinine rise. But it will just stop there, and next day the creatinine rise will improve and vasoconstriction will improve. They won't get tubular necrosis. So that is also an observation which we used to say that CIN is recovering quickly, right? So now I'm repeatedly telling this is reversible, this is okay, but why so much fuss? So as I said, when it comes to people with reasonable kidney function or people without diabetes, they improve. But people with advanced chronic kidney disease, sometimes they sustain permanent damage. Now 20% of the people who develop contrast-induced nephropathy, they sustain permanent renal damage and persistent increased serum creatinine, not improved. So that's the sad part. And also, as I mentioned earlier, the in-hospital mortality after any acute kidney injury, basically, and it matters to the CIN as well, a 5 times high mortality just because of you are getting a CIN. You can understand the gravity. And also, the long-term follow-up studies have shown that mortality in 1-year follow-up and mortality in 5-year follow-up is much worse. So you should prevent contrast-induced nephropathy by all costs, right? And also, the worstly affected people are the people who are having the most advanced chronic kidney disease. So, person with a creatinine of 300, 400 is definitely most likely going to get more damage compared to somebody with a creatinine of 150 to 200, right? So, as you worsen CKD, your damage is worse. And And also, if you get an AKI, now, for example, imagine now there is a patient with sepsis-induced AKI, and we know that AKI is due to sepsis, and you are waiting this patient to improve. The patient is in the ICU, and but suddenly you want to do a contrast study, right? So that's the worst referral I'm getting. So because now I'm expecting a recovery of AKI, and I'm managing sepsis, but now here you want to do a contrast. But if the requirement is there, you need to do it, right? If the requirement, for example, if you are suspecting a pulmonary embolus and you want to do a CTPA, I can't refuse that, because you are going to that is going to matter to the life of the patient. So we have to do in those instances, but that is going to jeopardize the recovery of the renal recovery. And so what we have to do is, when the request comes, and even when you are requesting from me, whether is it okay to proceed, you need to weigh the benefits versus risk. Right? Whether we really need to do this contrast study is the first question, and that's what sometimes I discuss with you. Can you do like a duplex scan instead of doing a low-volume CT angiogram to diagnose? Can you do like a non-contrast CT instead of doing? So that is my request in the extreme cases. But if the indication is life-saving, we need to proceed taking the risks. Right? So there are some traditional risk factors. So it's a long list, but I will just simplify it. There are fixed, non-changeable risk factors as well as modifiable risk factors. Diabetes is we can't change. It's a non-modifiable risk factor, and pre-existing renal impairment is the most important risk factor. And also cardiac failure, mind you, it itself is a different risk factor. And especially this comes when somebody is coming with an acute MI, where they're having an MI, they're having AKI, and they're having cardiac failure, and they would do a coronary angiogram. So that's the worst case scenario. And also cardiogenic shock, and also renal transplants, they are more prone to get acute kidney injury. And the modifiable risk factors are the ones which are very important. And just go through one by one. And sometimes these things we can change. So one is the volume of the contrast media we are administering. We'll discuss it later. That is something you can't change. That is to do with the radiology department, and also people who are performing angiograms. And also the anemia, low albumin, dehydration, and these things you can change, right? For example, if somebody is waiting an elective procedure who is anemic and who is having low albumin, you can address those problems and plan out the contrast study. If you are doing it like in months or 2 months time, you can plan out these things, isn't it? You can change. If you can give a blood transfusion, you can start iron treatment, and you can give a high protein diet and try to improve these factors if you are doing it in few months time. But if this comes in the context of an acute requirement, you can't do anything for that apart from the correcting dehydration. And there are a few drugs. You already know about these drugs, obviously. ACE inhibitors. The mechanism of action of ACE inhibitors is basically to reduce the blood flow to the kidney, right? So what it does is it constricts the afferent arteriole and reduce the amount of blood coming to the kidney, because the job of the ACE inhibitor is to rest the kidney. So if you rest the kidney, your CKD won't worsen. So that's why we give ACE inhibitors to people with CKD. But by giving an ACE inhibitor, we are constricting the blood supply to the kidney at the resting time. So if you want to do give contrast for somebody who is already vasoconstricted, that's not good, isn't it? So you should stop ACE inhibitors, and that depends on the degree of renal impairment. We'll discuss the numbers. Whether we really need to stop ACE inhibitors in everybody, not really. And people with advanced chronic kidney disease, obviously, at least 1 to 2 days time. Do you need to stop it like a week before? No. So at least 1 to 2 days before, it would be enough, depending on the degree of renal impairment, right? And when to restart, we will discuss. And also diuretics, obviously. Diuretics is going to reduce the intravascular volume, and that is going to worsen acute kidney injury. And also NSAIDs, the action of NSAIDs is the afferent arteriolar constriction. So that is going to reduce the blood supply to the kidney. So you should not give NSAID within 24 to 48 hours when you are doing a contrast study, right? So now we discussed earlier, contrast CT, right? It is intravenous contrast administration. It's not bad as we think. Contrast CTs, the chances of you getting contrast-induced nephropathy is quite low than we think. So most of the referrals I'm getting are for contrast CTs. So I have a kind of a relaxed approach when it comes to contrast CTs. If somebody is having renal impairment, and if they are not having very severe renal impairment, for example, if their EGFR is not less than 30, I usually have a relaxed approach. If I can correct the other things, stopping ACE inhibitors and avoid volume depletion, you can proceed with a contrast CT without getting much problem, even if they are having a reasonable CKD. But intra-arterial, yes, I'm very worried. Angiograms, we have to have a lot of thinking before proceeding with an angiogram. And highest rate of acute kidney injury is associated with angiogram, and especially intervention. The PCIs, not just the coronary angiogram. If you want to do a stenting, and if you are meddling with arteries and plaques, the chances of you getting acute kidney injury is much higher. And also the amount of contrast being used in just a coronary angiogram versus PCIs is hugely different, right? We'll discuss about the volumes, but at a coronary angiogram, the volume of contrast we are using it can range between like 50 to 100 ml. But coronary angiogram with a PCI, sometimes we tend to use 150, 200, it can go up to like 500 ml. So depending on how complex is your coronary anatomy. So it is more problematic, right? And especially in the context of a myocardial infarction, risk is very high. So now I said earlier, now what we are using nowadays is a different type of contrast media. They are called non-ionic and low or isosmolar. So these are more kind of radiology stuff, but it's nice to know. So earlier days, we used more high or smaller contrast media. No longer we are not using, even in Sri Lanka, we are not using high or smaller ones. Say probably last 5 to 10 years, we are not using high or smaller ones. What we are using, most commonly using is a low or smaller contrast media. And these are iodine-contained contrast media, iodinated contrast media. That is, the commonest one we use is called iohexol. That's, virtually most of the instances in Sri Lanka, we are using iohexol. That is a non-ionic and a low or smaller media. The chances of acute kidney injury is much less. But what's the best? Is it the low or smaller one? Oh, no, there is another preparation. I'm not 100% sure whether we have it in the government sector, but that is called an isosmolar agent. That's called iodixanol. That is an isosmolar. So isosmolar means osmolarity is similar to the plasma. The plasma osmolarity is roughly around 280 to 290. And iodixanol has 290 osmolarity. Iohexol, though it is called low osmolar, it is still having like 500 to 600 osmolarity. So it is still high, but not as high as what we used in the past, where they are having osmolarity about closer to 1000, right? So, so just nice to know if somebody of you want, if you want to get a contrast study, if you're worried, and you can ask whether you have the isosmolar, and you can preferably ask whether you have isosmolar one to get, right? And the contrast volume. And most of the instances, volumes below 100 ml or 125 ml has proven to be safer, provided the degree of renal impairment is, modest. But now there are a few studies done to give very small amount of contrast. For example, less than 10 ml contrast to check the arteriovenous fistulas created in people who are not on dialysis. They are still having advanced CKD, but they are not on dialysis. And they are the people most vulnerable to contrast media. I can understand. Now, people who are not on dialysis are the people who are having little bit of renal function left, and they are functioning with that without going into dialysis. Right? What about people on dialysis? Are we worried? Not really. Because people on dialysis, when they are putting on to dialysis, say a few months, that remaining bit of residual renal function is gone. So basically, they don't have kidneys, and their function is being done by the machine. So we are not at all worried. And if somebody is having on twice a week or thrice a week dialysis, and if you ask a question from me, are you worried? No, I'm worried, but I'm not worried. But there's a subset of people who have a reasonable urine output. Even if they are on dialysis, if they have a reasonable urine output, then they are prone to get CIN. And somebody who is on once a week dialysis will be pushed to twice a week, or twice a week will be pushed to thrice a week by giving contrast. But if you're anuric and on dialysis, don't worry. You basically need not to ask that question from us. And if check the urine output of the patient. If patient says only 100 ml I'm passing, I'm on dialysis for the last 5 years, you can give the contrast without any or angiogram or whatever you to play around, you can do whatever you want. But people with a urine output with advanced kidney disease, it's important, and especially people on CAPD. Now, people on chronic, continuous ambulatory peritoneal dialysis, some of them, they have a reasonable urine output. And they can go on with CAPD without moving into dialysis because they have a reasonable renal function left. And those people are at risk developing a CIN. So we are worried about those people when you request a contrast study, but not somebody who has a low urine output. And the worst scenario is people with advanced chronic kidney disease. For example, I have mentioned the figures. People with creatinine about 400, 500, even with a 20 to 30 ml of contrast can cause acute kidney injury. So these are the contrast volumes we are using. Usually for a contrast CT, we use about 50 ml, sometimes less than that. Angiography is 100 to 120. Now these are like very modest numbers. These are like generalized numbers. The things going to be different from patient to patient. And diagnostic coronary angiography, as I said, it can vary between 30 to 100, but coronary interventions can go up to 150 in average, but it can go much higher than that. So how to prevent CIN? So having all that knowledge back in your mind, risk factors and who are the at-risk people, the important thing is to identify the population at risk. So that's your job when you are referring to me, when you are deciding, okay, I'm going to do the contrast study, I'm going to ask from the nephrologist. No, so before that, you identify whether my patient is at risk of getting, and am I going to do it before asking the nephrologist whether it is okay to do it, right? So who are at risk? People with an EGFR less than 60, they are at risk, especially those who are having proteinuria, right? For example, if your EGFR is 50, creatinine is just 1.5 or 1.6. But if they are proteinuria and also they are having other comorbidities like heart failure, diabetes, and likewise, so they are at risk, right? And their risk, we would consider them as mild to moderate risk, right? So when their EGFR is less than 45, even if they don't have proteinuria, the risk is much higher, right? And when they have EGFR less than 45 with proteinuria, risk is much, much worse. And especially people who are having EGFR less than 30 are at a very high risk. So we consider people with EGFR less than 45 with proteinuria, they are having moderate to high risk, and less than 30, they are having high risk, right? So depending on the risk. So then how to prevent? How to prevent those who are at risk, how to prevent? Now we can go back to our mechanism and address each one of the problem and see how to prevent CIN, right? So what we can change, contrast molecules inside the kidney. How can we change that? We can reduce the amount of contrast we are giving, right? So then the amount of molecules in the kidney will be less, and or either you don't do it. So that's the easiest, right? So how to prevent? Now I said there is a direct cellular toxicity. That direct cellular toxicity happens through some oxygen-free radicals. And there have been some postulated mechanisms to reduce the amount of oxygen-free radical generation by giving certain drugs. We'll discuss in the next slide. That's one way. And now the other mechanism is increased viscosity in the tubules. How can we reduce the viscosity? By keeping them hydrated, isn't it? So either keep them hydrated or you reduce the amount of contrast you are giving. And the other mechanism is intrarenal vasoconstriction. How to prevent that? The drugs which are causing vasoconstriction, so avoid those drugs. So these are the suggested preventive measures and mechanisms of action. You reduce the amount of contrast, prevent renal vasoconstriction by stopping NSAIDs, ACE inhibitors, or ARBs, and reduce the blood viscosity by prevent dehydration and also giving intravenous fluids. And the last bit, that's a bit interesting, counteract the reactive oxygen species. The postulated drugs are the N-acetylcysteine, which was very popular like 5 to 10 years back. You might have given yourself NAC in most of the instances. And also sodium bicarbonate also has some effect on reducing the reactive oxygen species. So whether they are really going to be used in the clinical practice is, now this is just the mechanisms, right? These are postulations. But whether they are really acting in the clinical context is going to be dependent on the evidence-based medicine. Whether studies have showed whether these things are really effective. So that's where we are going to discuss next. So CIN prevention, one of the most important thing is hydration. Now, across the borders, there is a universal agreement that fluid and the hydration is definitely going to avoid CIN. So there is no argument about that. And that's a standard practice. There is enough evidence to say that hydration is going to improve. So how to hydrate is the question. So this is the most common practical issue you will encounter if you're sending the referral in the morning and the patient is awaiting the study in a couple of hours time, right? So that's a practical issue. So there are two types of regimes we use. So one way is what we practice in Anuradhapura is we give 3 ml per kg fluid. It's either saline or sodium bicarbonate that can be given over an hour prior to the procedure, and then ideally this has to be given during the procedure as well, and then continued for about 6 hours afterwards to 1 to 1.5 ml per kg per hour for 6 hours. You give it. So this is quicker, right? Because you can start this about an hour before. So if you are in a hurry, so you can just start it and continue it and finish it. So, but in non-urgent patients, the better way is to start hydration a bit earlier, right? So you can start the hydration 6 to 12 hours prior. And if you're not in a hurry, if you're planning an investigation, kindly admit these patients, kindly do creatinine early and plan out, kindly admit them either on the previous day, especially those who are having significant chronic kidney disease, admit them on previous day, start a drip 12 hours prior. You can do that, right? Or 6 hours prior and continue it into procedure and give it for another 6 to 12 hours after the procedure. So that's the best way, right? So what's the type of fluid we are using? That's the next question. Saline versus bicarbonate dilemma, all right? So the sodium bicarbonate, there are a lot of studies done to compare between sodium bicarbonate and isotonic saline, and they are giving very kind of conflicting mixed results. So essentially, the practice is unit based or rather center based, and some centers even in other countries they tend to use more bicarbonate based practice. And what we are practicing in Anuradhapura is also more kind of bicarbonate based regime. But now there was a time the bicarbonate was not available, right? About a month back, bicarbonate was out of stock. So then I advise everybody to use saline, right? Because the evidence is equivocal. So there is no real evidence to suggest bicarbonate is really superior over saline. So still I'm suggesting if you find it difficult to give bicarbonate, saline is good enough. And the most important thing is, I think we are right now in an economic crisis. The bicarbonate is so costly compared to sodium chloride. And so perhaps we might move towards more kind of sodium chloride based protocol in the future, which will be better off, right? And so as I said, there are large population-based studies involving 5,000 odd people have confirmed that there is no huge difference between sodium bicarbonate and saline. So you can practice either, and there is not huge difference, right? So what about N-acetylcysteine, NAC? So some years back, we tend to give IV NAC, right? Which is kind of very dangerous drug. IV NAC is very dangerous, it can cause reactions a lot. And when you are giving IV NAC for people with liver failure, you tend to get a lot of reactions. And it's not worthwhile to give IV NAC, which can cause reactions and cause blood pressure drop and a lot of other problems which can cause acute kidney injury by itself, to prevent a CIN, right? So giving IV NAC is completely out of the context and is no longer practiced elsewhere in the world as well, and we are not practicing it in Sri Lanka, right? So no IV NAC. Oral NAC, people are giving, but there is no real data. So the final conclusion is NAC is out, and there is no oral NAC is also costly, and no point of giving these things without having major benefit. What about dialysis? So that's the next question. Sometimes you might ask from me. Okay, this patient is having a CKD, creatinine is 500, still not on dialysis, but we will give contrast and we'll dialyze next day, and whether things will be okay. So that is one of the biggest myths, right? So there are a lot of studies done to compare whether if we do dialysis immediately after contrast, whether it is going to improve the course of CIN. But there are clear evidence that it's not. And in fact, people have tried CRRT. When they are giving when they are giving contrast, you start CRRT and try to get the stuff out from the body in the real time. But still, it has not shown any benefit, because, as I said, the action is very instant, right? The renal vasoconstriction or the tubular necrosis action is very instant, and you will get irreversible changes before you try to dialyze. And so there is no place doing dialysis. And in patients who is already on dialysis, are you going to plan dialysis on the neck? No, not really. If somebody is already on dialysis and annually I said they don't have kidney, you proceed with your study, and we will do his dialysis on the relevant day, right? So it's not going to improve it, right? So that's something to remember. So we are so basically we have discussed a lot related to the practical aspects of iodinated contrast media, iodine containing ones which is being used for angiograms as well as contrast CTs. So how to prevent and how to identify at-risk people, and what are the after effects and how significant is this problem. So moving on to the last part, gadolinium contrast is a different type of contrast. Gadolinium is being used in MRIs, not in the CTs. And that is also a contrast medium, but that is not an iodinated contrast. That's a different gadolinium-based contrast. Does it have the same effect, or does it have different effect? So we'll discuss. So gadolinium is known to exert nephrotoxicity in a similar fashion as iodinated contrast media, right? Though they are molecularly different, the mechanism is similar. They exert same degree of vasoconstriction and nephrotoxicity, but there had been some observations that the gadolinium-induced CIN is not as bad as iodine-induced CIN, but it depends on your degree of renal impairment, right? So the risk is similar, and the preparation is similar, the risk factors and everything is similar. So gadolinium also you have to consider as a nephrotoxic agent. But more tricky part related to gadolinium is not contrast-induced nephropathy. So some of you might be aware of this entity called nephrogenic systemic fibrosis. So if you haven't heard it before, it's an interesting condition where when somebody is exposed to gadolinium, and if that patient is having renal impairment, that gadolinium tends to stay in the body longer than we think and getting concentrated in the tissues, and it can cause tissue fibrosis. And this is a very severe and potentially a lethal condition where you starts getting fibrosis in your skin. And then if you are getting exposed to more and more gadolinium, or 2 or 3 MRIs, this fibrosis can start affecting your internal organs, the heart, the liver, kidney, and all the internal organs, and cause like fibrosis of the rest of the body. So, and when it comes to organ involvement, these are lethal situation. It's like systemic sclerosis where you get fibrosis everywhere. And this condition is not reversible, and there is no treatment, and there is a relentless progression of nephrogenic systemic fibrosis. So this is something you need to remember when you are requesting gadolinium-based contrast MRI. If somebody is having significant renal impairment, for example, people with CKD4 at 5, and especially when the eGFR is less than 30, gadolinium is considered a kind of a relative contraindication, right? So this is nothing to do with contrast-induced nephropathy. This is not contrast-induced nephropathy. This is a different entity, but that is you need to consider. And there had been quite a few requests coming in my way over last few months where you really need to give gadolinium and patient is having significant CKD. So unfortunately, I had to say no, because the risk sometimes it can go up to 1 to 7%. 7% of risk of getting NSF. It's a quite high number, right? When somebody is getting MRI and there is a 1 in 9 times or 1 in 10 times chance of getting NSF and can die of NSF is not acceptable. So when the eGFR is less than 30, I tend to refuse. And not myself. I mean, it's a worldwide recommendation where you recommend against recommend against gadolinium. But if you really want to do, because for example, there's a tumor, you want to know whether it is growing or not to decide on your treatment. If you really want to do it, and there are some gadolinium-based contrast, there are different modalities of gadolinium-based contrast, different versions, which are considered safer. There are 3 generations of gadolinium contrast, first, second, and third generation. The first generation is the older ones, which are associated with very high risk of NSF, and they are absolutely contraindicated when eGFR is less than 30. But if you really want to do, you can choose second or third generation contrast media, which are associated with lesser degree of NSF. But if you are a dialysis patient, right, they are the highest risk people. If you are a dialysis patient and you don't have kidneys, and they are at highest risk of developing NSF compared to other people. So sometimes, you really can't do gadolinium-based studies in those people. So it is completely different to CIN, you can understand. Right? So, so these I have discussed. And so the good thing about gadolinium contrast and NSF, and there have been some studies, people who are getting exposed to gadolinium, they tend to dialyze immediately after gadolinium contrast, and there had been evidence to say that chances of NSF is less. So this is where you can use dialysis to prevent NSF, not to prevent CIN. People who essentially need to go through gadolinium contrast, and you can try. There are some protocols. You try 2 sessions of dialysis, one right after the gadolinium contrast and another one after 24 hours. So that can mitigate the effect of gadolinium contrast. And but we are not going to dialyze people, with an eGFR of like 30 or like that. But when the eGFR is really low, less than 15, or somebody who is already on dialysis, we can arrange dialysis right after the contrast study, right? So that basically brings us to the conclusion of this presentation. So I'm again, I'll be very thankful to Clinical Society for giving me this opportunity, and also thank you very much for everybody of you to attend this lecture. And I'm open to your questions.